Welcome to Legal Nurse Podcast. I'm pleased to have the opportunity to introduce you to a legal nurse consultant who has extensive experience in the labor and delivery, high-risk population, and forensic nursing. She currently works both bedside and as a charge nurse on a labor and delivery unit. She works with recovery area patients as well as the postpartum unit, caring for birthing people and their families. And then she also serves as a forensic nurse examiner in her local emergency department. Welcome to Ashley Jefferson. Ashley, welcome to the show.
Thanks so much, Pat, for having me on.
When we talked before we planned this podcast, we discussed a common medication that's been around for decades. I feel like this drug has been used for decades, so it's safe and effective and there's no risks associated with it. Is that right?
That is not right. There are definitely risks with this medication that need to be explored and paid attention to whenever it's being utilized, for sure.
And we are talking about Pitocin, a drug that used to be used for women who said, I'd like to have my baby on a Friday so that I could recover over the weekend and go home on Monday morning. So let's just plan the delivery for then. Tell us about today, how it's used for women who are in that birthing process.
So Pitocin is the brand name for the synthetic form of oxytocin. And that's a naturally occurring hormone that our bodies produce. In labor and delivery specifically, though, it's used and whenever the patient is still pregnant, we use it for two main reasons. And that's to either induce labor if we need to get things started, either for a medical reason or electively. It's also used to augment labor. So you come in and your water is broken or your contractions have already started, but they just kind of slow down and don't effectively dilate your cervix. And so then we end up starting the medication as a way to get stronger and more frequent contractions. And then this way we're able to facilitate the birthing process. And it's a medication that's administered through the IV, and just it's a super useful tool in the toolbox, but it does have its own risk factors that are involved.
I can tell from the way you answered me, Ashley, that you have given this explanation to more than one woman in labor.
Yes, definitely. It is used quite frequently.
Then you mentioned the risks, and I'd like to focus on those because those are often the things that legal nurse consultants might be asked about in terms of, was it used appropriately? Was it used according to the standards of care? Can you give us some insight as to how Pitocin can contribute to birth injuries if it's not used appropriately?
So it can contribute, it has such a powerful effect on the uterus and can cause contractions that end up being too close together. The contractions can be too long, and then they can also be too strong. And so if that occurs, then we don't have an adequate resting period, and the baby doesn't get adequate oxygenation while the contraction is occurring. And so if you have too many of those without that at least a minute in between contractions, preferably more than that, the babies are just essentially they start yelling at you, is how I describe it to patients. The fetal monitoring strip will show us indications that they're not liking the medication and they're not liking the effect of holding their breath for 60 to 90 seconds for what normal contractions should be. That's our usual goal, is to have contractions every 2 to 3 minutes, lasting 60 to 90 seconds or so. Anything more than that can lead to more of a decrease in oxygenation, and they ultimately have decreased oxygenation to their tissues and their brain, leading to birth injuries and specifically hypoxic ischemic encephalopathy is one of the more common ones. But they definitely need that moment to recharge in between contractions. And if the medication is increased too frequently, if it is not titrated, that's the term we use to increase and decrease it. But if it's not titrated appropriately, then we ultimately are just putting more medication into the body and not allowing the baby to get adequate oxygenation from the placenta.
You just talked about a medication that has some significant consequences for children. Can you delve into that term that just rolled casually off your tongue, the hypoxic ischemic encephalopathy? And for the non-OB nurses who are listening to this, well, first of all, we know that that condition can occur in adults, but under different circumstances. But for those who don't know that term, tell us about the implications of that.
So with HIE, hypoxic ischemic encephalopathy, it's a type of brain damage that's caused by prolonged oxygen deprivation. And so as a consequence of that, babies can have cerebral palsy, they can have seizures, and then death also is possible if there is a prolonged amount of time without oxygenation.
That sounds like that has huge consequences for future care, for the damages in the case.
Absolutely.
Ooh, that is a bad complication.
It is, definitely.
And it could be a reason why a plaintiff goes to see an attorney, plaintiff being the mother of this or father of this child, who have concerns about the brain damage that this child has sustained and the catastrophic medical care and implications for this child for the rest of their life. They may hire a legal nurse consultant to take a look at the record to determine what happened. Tell us about the standards that we can be accessing to help evaluate what happened to this laboring mother.
So in 2008, the NICHD, which is the National Institute of Child Health and Human Development, they standardized or they edited their standardized terminology for labor and delivery for fetal monitoring specifically. They initially established it in 1997 and then edited it in 2008. And so it's a set of standardized definitions, standardized guidelines, and we're able to be on the same page with, so if a provider says that it's a category 1 tracing and we're going to continue increasing the Pitocin, but the nurse reads it as a category 3, well, we know that we need to be doing something different and escalating up the chain of command if the provider is not agreeing with us. However, if the doctor is saying, oh, it's reassuring, and the nurse is saying that they're saying it's a category 2 or 3, then there are things that we want to make sure that we're all on the same page and making sure that we are communicating effectively and documenting the same thing also. And so if we're not following those standardized terms, then we ultimately can be there's misconception or miscommunication, misconceptions, and our treatment ultimately is going to be different. You're not going to do the same thing for a category 1 tracing as you're going to do for a category 3.
Have there been any changes in these definitions or the interpretation of these definitions since 2008?
No.
So that forms the bedrock, the baseline for our classification.
Correct.
Then you've mentioned a discrepancy between the interpretation of the tracings What goes into the knowledge base of the people who are looking at those tracings at the bedside in order to be able to come up with what is the correct category?
So different facilities have different training methods. A1 is our national organization for OB and neonatal nurses, and we have a training that goes over both basic fetal monitoring, intermediate fetal monitoring, and then they also have an advanced fetal monitoring course. So nurses can take that course and be educated and aware of what these terms mean and the management of them ultimately. Doctors, on the other hand, usually are not taught an extensive, they don't go through the same course. In med school, I've been told that they do go over fetal monitoring, but it's not to the same extent because they're not necessarily, they're just kind of getting the whole overview of things. They are not necessarily getting um, the explicit training like the nurses do. And so doctors more so get taught on the unit and in kind of on the job training, and then ultimately um, they can take their own courses and identify weaknesses where they need to learn more. But to my knowledge, the medical providers are not necessarily receiving the same fetal monitoring training that we do. So it's our job as nurses to also make sure that we're using those standardized definitions and educating. And so if a doctor says that it's one thing and you're saying that it's another, then finding that terminology for an ICHD to be able to educate and make sure everyone's on the same page. It just ultimately leads to miscommunication and inconsistencies. And if someone's not identifying something as an emergency, then we could prolong delivery and ultimately have more complications.
Mm-hmm. For those who are our listeners who are in various parts of the world, we recognize that the availability of fetal monitoring tracings and strips may be different. In the most modern, well-equipped OB unit, labor and delivery unit, is there a concept of a central monitoring station like there might be on a cardiac care unit where at the nurse's station, people can look at what's happening in labor room 2 versus walking into the room and seeing the monitoring equipment?
Yes, so most facilities have a central monitoring system, and so they are able to see the tracings in the room. They're also able to see other tracings from other rooms in their rooms, because some facilities are still having nurses take more than one laboring patient at a time. And then also there is a large screen usually at the nurse's station that you're able to see everybody's tracings. And so everyone's able to be, if you're in one room busy and not necessarily looking at your screen, someone else is out there and says, oh, hey, that room's having a deceleration. Let's go help them. And so sometimes you can get all hands on deck faster because we have the ability to see everyone's tracing.
I know in some telemetry units, for example, there's somebody assigned to look at the tracings and that's their only job. Is that similar in OB, or is it more the responsibility of the nurse taking care of the patient to be looking at the screen in the nurse's station?
Ultimately, it is the nurse's responsibility who's taking care of the patient, but it is a team effort. We don't just, we're all looking at it at all times. And so we when we see something, if the nurse isn't actually paying attention, then we're able to say, hey, your baby's decelling. Do you want help? And so it's a team effort. There are some programs, I believe, in the northeastern part of the United States where there is a remote fetal monitoring nurse, and they're not even in the hospital, but they are kind of doing like what the telemetry monitor techs do. They're all watching it, and then they're able to communicate with the patient's nurse, and kind of have that extra backup, and have that extra set of eyes. So some facilities are moving towards that model of care.
Hi, I'm Pat Iyer, and I wanted to tell you about a hands-on workshop that is coming up on June 5th, 2025. It's called Analyzing a Nursing Malpractice Case, a hands-on workshop. It gives you an opportunity to build case review skills that will help you keep clients and win repeat business. Attorneys need answers that they can use. They don't have time for a vague opinion or missed details. If you're not confident analyzing a case outside your clinical specialty, or if you're unsure where to start with the research, you're not alone. Many legal nurse consultants face the same challenges, especially with nursing malpractice cases. This hands-on workshop taking place June 5th, 2025, is designed to fix that. You'll work with experienced instructors, which are myself and Barbara Levin, to review a real case, identify the key issues, and learn how to find reliable sources that support your opinion. You'll know how to ask the right questions when an attorney first calls you, so that you get the information you need right from the start. You'll also get some clear examples of how to tell if a case has merit before you spend hours going down the wrong path. Be sure to sign up for this June 5th, 2025 workshop by going to this link, lnc.tips/analyzing. That link will take you to the registration page so that you can get your seat and get locked in to participate in this hands-on experience. And if you see this podcast after the workshop has taken place, the recordings will be available for you at that link, lnc.tips/analyzing. We'll show you how to close the gap between your clinical background and strong analytical skills. I'd love to see you sign up for that workshop and spend the day with us to ramp up your skills on analyzing a nursing malpractice case. See you there. I'm Pat Iyer, and I've got a question for you. Is this you? I'm not sure how to tell if a nursing malpractice case has merit. If you answer yes to that question, you might be hesitant when an attorney asks you for a quick opinion, uncertain how to evaluate the medical records or what information you need to gather. In our June 5th, 2025 workshop, we will walk you through the entire process, from the initial phone call to identifying red flags and building a sound analysis. Or this could be you. I don't feel confident about citing standards of care or finding supportive literature. Knowing the case was substandard is one thing. Being able to support that opinion about the care with credible sources is another. In our workshop, you'll learn how to identify relevant standards, cite them appropriately, and strengthen your opinion with solid research. Or this could be you. I get confused about the difference between writing screening reports and expert reports. Whether you are a behind-the-scenes LNC or serving as a testifying expert, this workshop helps you understand how your role affects your report's wording and communication with attorneys. go to this link, lnc.tips/analyzing, in order to sign up for our June 5th, 2025 workshop being taught by myself, Pat Iyer, and Barbara Levin, an experienced expert witness. If you see this podcast after that date, the recordings of our day will be available for you and you can learn from them. Be sure to go to the link, lnc.tips/analyzing, in order to get your seat for the workshop. I'll see you there. I'm Pat Iyer, bringing to you information about our June 5th, 2025 workshop. This is a day that we have set aside to help you learn how to more clearly and more efficiently evaluate a nursing malpractice case. With Barbara Levin and I at your side, you will have an opportunity to learn how to identify the 4 elements of malpractice and how standards of care will guide your analysis. We're going to cover the difference between being a behind-the-scenes consultant and an expert witness, and what type of information you should gather from the attorney-client during that first phone call that you get about the case. We'll talk with you through a set of medical records based on a real case so that you can determine the case merits and get hands-on experience looking at the elements of malpractice. You'll learn how to use research and literature to support your opinion. What sources should you be checking out based on the issues in these medical records? And you'll discover tips for presenting your findings clearly, whether you're screening the case or you're writing a full expert report. Barbara Levin and I are both experienced expert witnesses and will guide you based on our experiences in evaluating cases. Sign up for our June 5, 2025 workshop, Analyzing a Nursing Malpractice Case, by going to this link, lnc.tips/analyzing. You'll have an opportunity to join us for that full day. And if you see this podcast after the event is over, you can invest in the recordings and get the benefit of what we shared. The link again is lnc.tips/analyzing. I will see you there. Hey, your baby is decelling. First of all, let's talk about what that means, and then what are the interventions when there is an ominous change occurring on the strip?
So deceleration, there are 3 kinds. 4 kinds. There are early decels, which mean head compression, and those are good. That just means baby's coming down, and it's a reflexive property that the baby has this decrease based on, hey, you're squeezing my head. My space is getting a little narrower. Variable decels are from cord compression, and then late decels are from uteroplacental insufficiency. And so that means that the baby's not being perfused through the placenta as well as it could be. And then prolonged decelerations are any decel that's longer than 2 minutes and less than 10 minutes, because once you hit a 10-minute mark, then that becomes a baseline change.
Then that becomes, I didn't hear the last word.
A baseline change.
So from a physiological standpoint, if I understand you correctly, the child, the fetus can weather a little bit of abnormal changes, but as it goes on, the risk increases, the risk of damage increases.
Correct. The longer that we're having those repetitive decelerations, the more the baby is having a lack of oxygenation through some point in the we call it an oxygenation pathway. And so somewhere in the pathway, the oxygenation is being cut off or reduced. And so the baby has a reserve and can handle it for a decent amount of time. But if there are other pregnancy complications that are also going or at play, then you kind of have to also look at the whole picture. And so if you know that babies are potentially compromised in another manner, for instance, if they have intrauterine growth restriction, and so they're measuring on the smaller side, then you're not going to watch those for very long because you know that baby's already potentially had decreased oxygenation. And so you want to make sure that you're intervening on those B cells and doing something about them. And if that ultimately means changing the delivery pathway and method that you're going to choose, then you have to have that discussion and provide informed consent to the patient because ultimately they do have the right to refuse either a assisted delivery or a C-section. So it's just making sure that everybody is on the same page and educating and providing that informed consent conversation.
And that would be another discussion on how fast you can get all the resources together in a facility to do an emergency C-section with all of the steps that are necessary to collect the people and the room and the equipment to get that set up. Clearly,
Right.
the faster you can do it, the better the possible outcome for the infant.
Correct. Yeah. The faster, depending on what your reasoning is, the faster you are able to get baby out, the better it can be. And so making sure that your team has those standards and policies in place of what do you do whenever the provider is not in-house and your baby is having these frequent decelerations, making sure that you are using just you're being an advocate for your patient and making sure that everyone understands the ultimate risk. So just getting all of those things into place and like you said, having everyone on the same page and getting everyone available quickly. I've seen a delivery in 6 minutes from time we called it to baby being born. So
Wow.
it can happen very quickly. But if you have someone who comes in from the ER and says, "Oh, I have a cord between my leg and you need an emergency C-section," that might take a little bit longer. You don't have an IV in place, and doctor wasn't even aware of them if they aren't in-house. And so most facilities have a 30-minute call time. And so doctors have 30 minutes. There are still some facilities out there that don't have anesthesia in-house. And so if it's a 30-minute turnaround time, then you also have to keep that into mind or keep that on the forefront whenever reviewing these cases is that not everyone has the same setup as far as their staffing goes. And so if all of those pieces don't fall into place correctly, then it just leads to a longer time between the moment that you said baby wasn't receiving enough oxygen, we need to do something about this, to delivery.
So many things can go wrong, Ashley. It's a wonder
They
we're all normal. Ugh.
they can, but thankfully babies they're definitely strong, they're fighters, and that reserve is everything. And so even having complications or having frequent decelerations, there's times that babies come out and we look at them and we're like, really, you had to give us all heart attacks while we were taking care of you, because their tracing might look absolutely horrendous. We might be having frequent decels, and just being more and more concerned, and we facilitate a faster delivery and they come out and they are screaming and pink and have 8, 9 APGARs and all is fine with the world. They just wanted to come out. And so
Hmm.
it it doesn't always end um, catastrophically, but it's it is a risk, and especially using this medication, it's just something that we all have to be aware of and be on the same page with our care.
Well, the healthy screaming child with the APGAR of 10 is not going to end up provoking the kind of questions that would come up leading to a family going to an attorney. The
Right.
attorney hears a set of facts and then picks up the phone and calls the legal nurse consultant. Let's say the legal nurse consultant is not familiar with OB. What kinds of words or aspects of looking at the medical record should the LNC be focusing on when that initial call takes place with the plaintiff attorney and the attorney says, do you think this is worth getting the medical records on?
In that case, I usually say that because there could be reasons in pregnancy that should have prompted a further review or a different plan of care before the patient even got to the hospital. Um, I recommend that these cases are reviewed by someone who is trained in fetal monitoring, is trained in OB, mainly because it is so specialized. And so it's something that whenever an attorney says, we had APGARs of 1 in 4 and your pH was 6.8 and the baby went to cooling, all of those are signs that baby had some kind of um, insult. And so we need to look at that further. But there are still times that babies come out with an APGAR of 8, 9, and then all of a sudden, 10 minutes after delivery, they're having difficulty breathing and they're having problems. So they can come out and still have generally speaking, you're not going to have that high of an APGAR with that low of a pH and having metabolic acidosis. And that um, those are just some things that we are wanting to review as a whole. So we're going to want prenatal records. We're going to want fetal monitoring strips. Those two pieces are probably the two things that don't come with medical records because
Mm.
they are not, they're usually separate systems. So the fetal monitoring system is different. And so hospitals don't necessarily send those when they send the OB record, they send the hospital records. So sometimes you'll have to reach back out and say, no, I need the fetal monitoring tracing as well. You'll need to ask for the prenatal records because it all tells a story. And so those, along with mom and baby charts, we're able to kind of get that full picture. Um, but a lot of times, until someone is able to look at things, I've found things on, I've had a 8,000 page record and find things on page like random 462. And it's a placenta, usually placenta pathology is another one that we want to make sure we have. Because if if there was a placental abruption, we can see that on the placenta pathology result. And if we were running Pitocin specifically and the tracing is a category 2 that moves into a category 3, it just gives us that full picture of whether or not it was if there was an error with nursing care, with provider care, or if it was something that unfortunately just happened and had a bad outcome.
So to bring this back full circle, we started talking about Pitocin at the beginning of this call, and you've identified critical records of prenatal records, fetal monitoring strips. I assume that we're also going to see some flow sheets or maybe an electronic medical record that is connected to the pump that's delivering the Pitocin. Is that standard, or are there typically manual entries that the nurse is putting into the EMR keeping track of what rate is the medication being delivered?
So both. There are some facilities have switched over to what's called interoperability, and we're able to scan the pump, scan the medication, and it automatically we're able to verify. It's called infusion verify, and we're able to verify what the pump is saying. But that should be in the fetal monitor, or it should be in the medical record. It is a it can also be a manual process, and so you go into the flow sheet or into the medication administration record or MAR, and you can manually put it in as well. And so some places are still using the manual method depending on what their IV pumps are capable of doing. And so making sure you have the medication administration record, having the flow sheets, um, most of the time it's flowed over onto the flow sheets as well. So even if um, whether or not it's interoperability or if you're manually entering it, you'll be able to see it on the flow sheets in the medical record.
Everything that you've said in the last half hour, Ashley, has reinforced the need to have somebody with OB background looking at these details, because there are nuances that would escape somebody who doesn't have that training. What would be the best way for people to be able to reach you to ask for help?
To reach me, you can contact me via email. It's Ashley at genesislegalnurse.com. My website is genesislegalnurse.com. I'm on LinkedIn and Facebook and Instagram. So any of those methods to send me a private message are also available to reach me.
And Genesis is spelled Genesis.
Yes, ma'am.
Thank you, Ashley, for taking the time to share with us some of the details of this. I know we have just scratched the surface in terms of looking at some of the standard of care issues related to delivering this very effective but potentially dangerous medication. And when we think about the impact on the infant for having a reduced blood flow to the brain, it's chilling. These are lifelong injuries that no amount of tender, loving care can reverse when the cells were starved for oxygen during the laboring process. So legal nurse consultants become critical in helping attorneys figure out what happened. Was anyone negligent? Was there some other explanation for what happened to cause this kind of catastrophic injury?
Right. Absolutely.
Well, thank you for being with us today. And for you who is watching this on our YouTube channel, Legal Nurse Business, be sure to hang on for a few more minutes and find out what's coming up next in our next podcast. Remember Ashley as a resource in your OB cases. She's very knowledgeable and will assist you as a legal nurse consultant in handling your cases. Coming up next on Legal Nurse Podcast, hang on to find out about our next show. Coming up next on Legal Nurse Podcast is a program that I did with Barbara Levin on the topic of report writing. The way that you structure your report is critical and can have a huge impact on the success of a case. In this program, you'll get some practical tips that cover things like report structure, content, the need to be objective and unbiased, the importance of proofreading your report, and many other topics that Barbara and I cover in this approximately 1 hour long program. You're in for a treat. Be sure to get the next Legal Nurse Podcast on report writing.